Welcome everybody to tonight's webinar. My name is Helene and alongside me is my colleague Jade, and we are the Workforce Development Officers at the PHN. I'd like to begin by acknowledging the traditional owners and custodians of the land and waterways from which we are zooming in from today. We recognise their diversity, resilience and their ongoing place that First Peoples hold in our communities. We pay our respects to elders, both past and present, and I wish to extend that respect to any First Nations people connecting today. We commit to working together in the spirit of mutual understanding, respect and reconciliation. We support self-determination for First Nation peoples and organisations, and we'll work together on closing the gap. So welcome to our first session for our orthopaedic webinar series, Foot Pain. I'll just do just a little bit of housekeeping. The majority of our webinars are recorded and freely available on our YouTube channel. Jade has that up on the screen at the moment. We have a practice communique that we send out fortnightly. That's got all information on it, including internal and external calendar of events. You can also subscribe to our fortnightly newsletter via our website. Please make note of the PHN health pathways on the screen at the moment. This is related to the topic tonight. And for this evening's meeting, all participants will be put on mute for the course of the meeting. And should you have any questions, just type them in the questions box and I will address them at the end of the session. They'll all be answered anonymously, and I will answer them on your behalf. So I will take this time now to introduce our first speaker, Dr. Michael Galvin, orthopaedic surgeon. I will hand over to him to commence the session. Thanks, Mike.
Thank you very much. So my name's Mike. I'm one of the orthopaedic surgeons in Geelong, and one of my subspecialty areas is foot and ankle. So thanks for the opportunity to speak to everyone this evening. What I thought I would talk about are some orthopaedic foot conditions not to miss. So foot pain in itself is a pretty large topic, and trying to do that in 15 minutes, I don't think we'd do it much justice. But what I thought I'd do is try and base this on a pain location approach, so that we could look at ankle pain, hindfoot pain, midfoot pain, and some toe pain. And when patients present with pain in those areas, some of the diagnoses which an early referral I think is warranted. Okay, these are really the conditions that I think are time critical, and that being referred early can potentially improve these patients' outcomes. It's not designed to be an exhaustive list of the different types of foot pain, but just some of the important things that I see. So if we start with the ankle, there's really a few different regions that I would consider that you'd want to break this up into. The first is lateral ankle pain. So the vast majority of the lateral ankle pain that you're going to see in general practice is really going to be the simple inversion injury and the fairly simple ATFL sprain. And that's something that is really appropriately managed at the GP level with the addition of some physiotherapy. But the thing that I think is often overlooked is a syndesmotic injury. So when that pain presents a little bit more proximal, and it can often be a very difficult injury to differentiate from an inversion injury. For me, the key to doing this really comes down to some history taking and also some clinical examination. The usual mechanism for a lateral ligament injury is an inversion injury, so where the foot inverts inwards, whereas a syndesmotic injury tends to be an external rotation force, where the foot is essentially twisted outwards. And what that does is it damages the ligament on the inside of the ankle, the deltoid, and then with enough force, you eventually damage the connection between the fibula and the tibia, and you rupture the syndesmotic ligaments. Now, this may or may not be associated with a fracture. Typically, if it's associated with a fracture, these patients come through the emergency department and they get picked up in that fashion. But what I think is it often presents to the GP are the ligamentous injuries. And so for me, it's the taking of the history and asking about the mechanism of what happened, and then also examining the patient. So most patients who have had a lateral ligament injury will have pain and tenderness in the region just in front of or just anterior to the tip of the fibula. But what you find with a syndesmotic injury is they often have bruising on the medial side of their ankle, and then they've got a pain over the syndesmosis. So in most ankles, you can actually palpate that, and if they've got pain that's proximal to the end of the tibia, I've got a pretty low index of suspicion for being concerned about a syndesmotic injury. You won't pick all of these up on an X-ray if it's a purely ligamentous injury. So if you are concerned about that, then it's typically either a referral to someone like myself or an MRI scan. I think is really the best method of diagnosis because it allows you to image the actual ligaments. If we look at the inside of the ankle, so the two things that can often be confused with just a standard ankle sprain are really the injuries on the medial side. Okay, so again, the thing that I worry about on the medial side is that they've either had a sprain or a rupture of their deltoid ligament, or they've had an injury to their spring ligament. Again, a lot of this comes down to taking a history from the patient and really trying to determine the type of mechanism that was applied to their ankle. And in these cases, rather than an inversion injury, which gives you your ATFL rupture, these patients have an eversion injury, so their foot tilts outwards. The reason that I think that these are somewhat time critical is that unlike a lateral ligament sprain, where we would try very hard to manage the majority of them non-surgically, a complete deltoid rupture or a spring ligament rupture are often best treated surgically, just because of the forces that go across this region of the foot, and they often don't heal very well. And if missed, they can lead to a change in ankle alignment. They lead to valgus at the ankle, and they can also lead to a degree of flat foot or pes planus if not picked up early. The next thing that I see are Achilles tendon ruptures. And again, it's a reasonably important, timely diagnosis. And the main reason for this is if we're trying to get the best outcome for the patient and we're going to treat the patient non-surgically, we really want to get that patient into an Aquinas cast as soon as possible. And we want to do that ideally within 48 hours of the injury. And what that does, the reason we want that is what that does is it opposes the two ends of the tendon when you point their toes, and you want to keep them in that cast for 2 weeks. And what it achieves is some early healing and sticking together of the two tendon ends, so that when we transfer them into the cam boot at the 2-week mark with their heel raises, there's already a degree of tendon apposition and tendon healing there. And again, part of this is history based, so you're taking a history from the patient. What we find is they give a pretty reliable story for an Achilles tendon rupture, and the classic thing is that it's an instantaneous snap or pop that they hear. it's usually from a forced dorsiflexion. So when they're pushing off and their Achilles tendon is contracting and their foot is forced into dorsiflexion, and it simply overloads the tendon. The thing that you find clinically, and the two things that I use to make a diagnosis of an Achilles tendon rupture, this is just to demonstrate to you, is the first is when you palpate the Achilles tendon, there's a palpable gap, and you can see the imprint that my finger's left here in this patient. So you lose the resting tension of the Achilles, which is usually like a guitar string, so it's really has a fair degree of tension in it. And if you palpate it, you can actually feel the gap between the two ends of the tendon. That's often a lot of people worry about examining the Achilles tendon because they think that it might be uncomfortable or painful for the patient. But usually by the time they've ruptured the tendon, they're actually relatively comfortable because it's been a complete rupture. The patients who have significant pain associated with an Achilles tendon rupture are either partial ruptures, where there's a degree of tendon remaining and there's some ongoing tearing happening at that zone of injury, or it's people who have had musculotendinous tear and there's been damage to the muscle, and that muscle damage is painful. The second thing that I think is important to test is the Thompson test. And I usually ask the patient to lie down on the bed with both of their legs and both of their feet hanging off the end of the bed, like this patient situated here. I always look at their good side first, squeeze their calf to get an idea about how much motion I'm able to generate from this patient normally. And then you go to the affected side and squeeze the calf. And what you see there, just go back and show it to you again, is there's no motion of the foot, okay? The reason that I think most Achilles tendon ruptures, I think, are really a clinical diagnosis. If you have any uncertainty regarding the diagnosis, I think an ultrasound is the best way to confirm that. And if you are worried that they may have ruptured their Achilles tendon, I think it's reasonable to try and get that patient into a back slab with their toes pointed, so that if we do find that their Achilles tendon is ruptured on the ultrasound, they've already started their treatment. Okay. There'll be a group of patients like the lady in this picture here who gets told by her friends that she's got no pain, so she can't have an Achilles tendon rupture, who gets 2 weeks down the track and still can't walk, who eventually gets an ultrasound. And unfortunately, by the time you've been walking on it for a couple of weeks, the ability to treat this person non-operatively because the tendon has retracted is really low. So they're kind of they're committed to surgery if the diagnosis is not picked up early. The next, moving further down the foot, if we look at the midfoot, which really makes up the joint complex between the metatarsals and the cuneiforms and the cuboid, often confused with a lateral ligament injury, can be a base of fifth metatarsal fracture. So again, this happens with an inversion injury. The base of the fifth metatarsal is the bony prominence on the lateral border of the foot, and it is quite prone to fracture. The majority of these we would elect to try and treat non-surgically, but fractures in the region at the watershed area, which is where the shaft connects to the base, they do have a high risk of non-union. And it is important that you get those patients off that quickly. And that's something that, again, I'd be usually happy to see quite quickly. And I think it's reasonable to have a conversation with the patient as to whether or not they'd like that fixed acutely. The main reason for that being that when, because of the high non-union rate associated with some base of fifth metatarsal fractures, you performing a primary fixation does shorten their time to union and give them a more reliable result, particularly in athletes who are pretty keen to get up and go reasonably quickly. On the medial side of the foot, one of the things that I often see that gets missed or is a late presentation to me is a rupture of the tibialis anterior tendon. And unlike the Achilles tendon, it's not a tendon that we can really manage successfully without an operation. If they are treated non-surgically, they do get left with a foot drop, or they get left recruiting their long extensors. As you can see, this patient on the right here, they're using their EHL tendon to flex their ankle. The reason that trying to get to these patients quickly is the same reason as with the Achilles. If the presentation is delayed, the tibialis anterior tendon actually retracts proximally in the leg. And what that means is that when it comes to trying to repair that tendon, and quite often in these patients, it's usually in the setting of tendinopathy, and it's an avulsion from its insertion on the medial cuneiform. It's almost impossible to get that tendon back down to its anatomical origin. And what you find is that by delaying the diagnosis, you find that you have to repair this tendon in increasingly more proximal places the later it's picked up. And the more you have to proximalize that insertion, the greater the reduction in the lever arm of the tendon, and the weaker it is long term. The difficult thing is that because patients can usually compensate without a tibialis anterior, and they can recruit their long extensors, they don't often realise that they've actually ruptured a tendon. So they themselves may be the reason that the presentation is late, because they get a bit of pain. It's a bit sore on the inside of their foot where the tibia tendon attaches, and they just feel like they've got a bit of weakness and a bit of pain on the inside of their ankle. If you have if you see these patients, then really what you want to try and do is examine the patient at the level of the ankle. And the tibia tendon is the most medial tendon on the ankle where it crosses, and it's usually quite a subcutaneous tendon, and usually reasonably easy to palpate. So if you're examining the patient and you're unable to feel that tendon, and they've got weakness in active dorsiflexion, I think it's reasonable to get an ultrasound, because again, a reasonably easy way of making that diagnosis with an ultrasound rather than needing anything like an MRI scan. And the next midfoot condition that I think is worth talking about are really Lisfranc injuries. And this is something that we miss frequently in the hospitals because of the complexity of the foot, and the subtle Lisfranc injuries are really what present to me in a delayed fashion within the community. Again, a bit of this comes down to having a high index of suspicion and asking the patient how they injured themselves. Some of the common mechanisms that we see associated with Lisfranc injuries are a trauma applied to the top of the foot where the foot is crushed, Think things like being run over by a car tire, dropping something heavy on the foot. Twisting injuries on a planted foot. Again, the common things you see here are when people are in a binding. The things that often cause this are snowboards, water skis, wakeboards, horse stirrups, kite surfing, anything where the foot is got a tight strap across the top of it, and then a twisting force is applied, and the front of the foot is twisted. And then I've even seen it in athletes who either have another player who stands on their foot, or their foot gets buckled under their leg when they fall, and can bend the foot. The initial X-rays in a lot of Lisfranc injuries are non-diagnostic, and it's very easy to miss some of these really subtle injuries on a plain film alone. There is a degree of dynamic instability with these. So what I mean by that is that it is possible to have disruption through that area of your foot, and that in a non-weight bearing X-ray not see that because the bones sit in their normal position. What you would see when you examine these people is we often get this what we call sentinel bruising of the foot. So it's the kind of a pathognomonic finding with bruising in the sole of the foot that is associated with a Lisfranc injury. So if I see any patient who has a foot like this in the setting of having an acute injury, then I'm usually pretty happy to arrange a CT scan for these people, for these patients. And what that does is that really gives you a much greater appreciation of the complex anatomy in that region, and really allows you to see some really small fractures that are really easy missed on a CT, on a plain film. And moving to the toes, fortunately there's not too many toe injuries that are particularly time critical, and fortunately the only one that is actually really rare. So turf toe, which is a forced plantar dorsiflexion injury of the great toe, where the short flexors, or the flexor hallucis brevis, where after it's attached to the sesamoid, is ripped from the inferior part of the proximal phalanx. Again, X-ray findings are really subtle with these, and you might often won't see anything, and it's usually a diagnosis that's made with an MRI scan. Again, the reason it's time critical is that they are far easier to repair in an acute setting, and often if it's a delayed presentation, it may not even be possible to repair that, and they may need to have their first MTP joint fused together. So thank you very much, and if there's any questions at the end, we'll talk about it then.
Thanks, Mike. Could we hand over to the next speaker? I'm not sure if that's Ben or Narelle.
There we go. That's me, Helene. Oops.
Thanks, Ben. You can start.
How's that? Does that look all right? Thanks, Michael. That's a great setting for me just to talk about some of the conservative measures that we might use. And most of our referrals are orthopaedic related from the orthopaedic surgeons. So we do a mixture of the public work at university hospital and a mixture of private work as well. So I'm just going to go over some of the more common conditions that we see in the presentation. So again, we'll look at sort of some midfoot regional pain and management, some of the forefoot conditions that we see often, and some of the toe conditions. So one of the most common I think we see in the midfoot is the degenerative joint disease associated with arthritis, and that presents with pain, usually worsened by walking and activity, can be caused or exacerbated by tight footwear, can be associated with swelling, but most of the time these people are elderly and we see them, they're quite skinny, they don't have a lot of swelling or a lot of soft tissue, they're quite frail. One of the big things that causes that dorsal compression, you can see on both of these images, is when the foot's either pronated or the midfoot's collapsed, or the Achilles tendons are quite tight. So dorsiflexion's limited once they're in a standing or a mid-stance position. So progressing from mid-stance towards toe off, if dorsiflexion's limited, then the midfoot is the compensatory joint or joints that takes the brunt, and that's when you get that dorsal compression and eventually degeneration and bone spurs, osteophytes. So the way we would look at managing that, if there's a lot of pronation, then we'd look at longitudinal arch supports to try and reconstruct or just hold that arch back up into a more neutral position. The other way to manage it, if it's quite chronic and quite sore and doesn't really respond well with foot orthotics, maybe a carbon shoe stiffener, which reduces, effectively it's a carbon plate that makes the shoe stiff, so it reduces the bending through the midfoot with walking. The other method sometimes is the rocker soled shoe, and that's one that's retail shoe, and there's not many around now. There used to be lots, but there's only a few that I think are much good. But if we can roll that foot from mid stance through to toe off, what it effectively does is reduces the extension of the toes, but also the bending moment that we were talking about, the extension of the midfoot. Sometimes this is an example of a fellow who I've been seeing for quite a while with advanced arthritis, particularly collapsed midfoot, bony degenerative changes, and we have managed him reasonably well with a longitudinal arch support. This is quite an old one, it looks a bit grubby, and we might match that up with an AFO. That's an Arizona style brace, like a gauntlet. So we strap that up with the foot orthotic as well as custom made boots. He had so much deformity, he wouldn't ever fit into any retail shoes that would be comfortable or would in fact be quite dangerous, which is why he came to us too. Already covered, so the Lisfranc injury, I won't sit on this slide for too long, but obviously there's lots of variations of presentations, a mixture of sprains, and the bad ones, of course, are the fracture dislocations that need the open reduction internal fixation. There's three columns of the midfoot that are used to categorise these injuries, and I won't be going over that, just to demonstrate that it has lots of different variations. So when this type of patient's always managed by the orthopaedic team, so when that foot's safe to come out of a cast following surgery most of the time, our job would be to immobilise the foot and the ankle. The other thing we may do is sort of reposition or just maintain the arch support if we can, and that might be done inside the cam boot as well. So if it's a low-grade injury, sometimes we're referred just to put someone in a standard cam walk AFO. And here's a fun fact. I had a student come through, one of the Deacon's medical students, we bring them through a place every 6 weeks, but they pointed out that cam walker was cam meant controlled ankle movement. So that's new. After that many years, I had no idea. So plus or minus the foot orthotic, again, following surgery or cast. So if they're more involved, or they're a lot more, there's been a lot more involvement with surgery, then sometimes we may use a total contact cam walker, which is this style. So it's a clamshell type. It's got a bean-filled liner in it. Sometimes they're pump liners, and you take the air out or pump the air up to provide a more intimate fit, which in turn provides improved immobilisation, but also fills up the arch space at the same time, just for that extra support through the midfoot. Rocker soles can sometimes be useful if they're returning to activity. So the cam boots have rocker soles incorporated into them to facilitate the gait pattern or make it a lot smoother, to smooth out that walking pattern, to reduce the ankle movement that's required during the stance phase. So this rocker here has a rock that's quite proximal. The idea is to roll that foot off quite soon following mid-stance position. Again, the fifth, metatarsal fractures. We, like Michael said, are nearly always are from the rolling of the ankle or the inversion movement. So my understanding is the referrals will come to us if it's sort of a less than 3 millimeters of displacement, or there are some other complications involving the joint surface. So the idea, again, our role is to prevent the ankle from inverting, also immobilizing it in the sagittal and the frontal plane. So frontal plane's inversion, sagittal plane is sort of plantar and dorsiflexion. It's important to obviously stop inversion or the rolling from happening again, and just to try and deactivate the perineal muscles that pull on the site, particularly when there's an avulsion style injury. So immediate application, a Cam Walker AFO once referred after perhaps cast or sometimes fixation, which is the standard type. We use pump liners with all of ours, and sometimes if you're wanting to get back into activity, particularly sports that have got a lot of directional movement like your netball and your tennis, basketball, that's just a bit of insurance to help, again, remove that possibility of inverting the foot. So one of the, it says forefoot, it should be, or it is metatarsal phalangeal degenerative joint disease. So we see, particularly in the elderly, but also in some people who have had some sort of trauma that's disrupted the joint, that's become arthritic or degenerative disease. So hallux rigidus is the first one, which is the diagram on the bottom. So there's literally no movement in the first metatarsal phalangeal joint, whereas hallux limitus, there is some movement, but it's usually painful because of end of range positions, at the end of range of extension and flexion, it's often painful. So the aims for us then obviously are to restrict that movement and reduce the pain, improve the walking comfort. So what we would use sometimes are carbon fibre foot plates, again to stiffen up that forefoot and the toes. And we may also look at incorporating rocker sole shoes. Sometimes if the person needs a rocker sole that's a custom made, we custom make the or modify the footwear. We might also incorporate the carbon foot plate at the same time. So metatarsal joint pain, metatarsal phalangeal joint pain is fairly common, particularly with your osteo and your rheumatoid patients, and obviously mostly elderly. And it's a mechanical pressure-related force or pain. It's usually involving fat pad atrophy, so they've got no natural padding under that metatarsal region, and ischemia can be also involved. So the bones are very prominent, and the signs often is the callousing. I'm in end stage, and this is not really, I guess, relevant, but the diabetic foot's a whole other topic, of course. But the neuropathic foot, when you get presentations of people with ulcerations, need offloading of those, but of that particular first metatarsal joint. That top diagram just shows that sometimes you'll find people present with the first ray or first metatarsals dropped in comparison to the second through to the fifth. So it's inherently lower therefore takes a lot more load. So the idea is to offload the destructive forces and the loading by sort of redistributing the pressures on the plantar surface. It can also be the role may be to reduce some of the shear forces and provide some cushioning if painful as well. So custom foot orthoses are the go-to for this type of patient. So the foot orthotics we make are generally this type of injury are palliative, so they're semi-rigid or softened type materials construction, often incorporating some cushioning or some shock absorbing materials, particularly under the regional spots that need it. Also incorporate apertures or cutaways under those high loading areas, like under that first metatarsal. And we also load areas where we can load and take pressure away from, by using an example as a metatarsal dome. So this is just a quick few slides showing how we take an impression of that foot. This is a cast looking from the heel towards the front. It's upside down, but you can see that first metatarsal, we've made a relief there just to reduce the pressure. That's it, looking at the positive model we've made, and then we make the orthotic from that. That's just looking from underneath. You can see where we've got this dark material is the area that's going to try and load up the second through to the fifth metatarsal heads. So that's the cutaway or the aperture recess. And that's a metatarsal dome that sort of reduces the pressure through the ball of the foot. There's just a couple of quick pictures to show. We use different variations of casting methods. More recently, we're using 3D scanners, and we can modify the design with CAD software, and we can then put these blanks into the mill and carve them out. And that's the product there. So this one is just an interesting one to demonstrate how this patient has got a fixed equinus plantar flex position, and they are getting a lot of loading, obviously, through the forefoot, the ball of the foot. They've also got a varus ankle positioning, quite a high arch or a cavus arch. And with that foot type, where there's a lot of loading through the ball of the foot, that can initiate an extension movement at the knee. So after time, progressively, you can find knees that are hyperextending. So by managing that equinus and balancing the foot pressures, can assist with the knee. So the options that we've got here, custom foot orthoses as a total contact design as well, medical grade footwear, and modifications that we do to balance out the shoes, so usually incorporating heel raisers and the forefoot rocker. So that's a lady that we see who has got an fixed equinus foot. She has a bit of plantar flexion, but that's about as much dorsiflexion as she can get. So we've got to take the shoe or the foot with the heel of the shoe down to the ground, so she can load and weight bear through the whole surface of the foot rather than the forefoot. Again, because it's a difficult foot to walk on, we might also incorporate a rocker sole into that shoe. Rocker soles are good if people aren't unsteady or unbalanced. People with frail people, you know, they can be a little bit tippy, so you've got to be careful about who you select to use the rocker soles with. Some conditions we have to control with an AFO, that we can't, if it's beyond managing with foot orthotics or ankle bracing maybe, then an AFO is used to control sort of gross instabilities or deformities. So they can also influence knee biomechanics, like the equinus foot. You can reduce that plantar flexion of the foot, reduces hyperextension. So with flexible instabilities, with no bony joint restrictions, then we can position that foot the best we can. Otherwise, we're looking at accommodating that fixed deformity. A lot of the time with accommodating fixed deformities, you do get a lot of high pressure areas, and you have to be wary of that and just make sure the pressures that we're putting on are in the right spots. A couple of conditions that we see commonly with that foot type, that varus sort of equinovarus foot, is the Charcot-Marie tooth patient, or patients with polio. So they also have complications, of course, with weakness or paralysis. So here's a
1 minute, Ben.
Okay,
1 minute.
Example of a varus inverting ankles. So CMT, high loading under the 5th metatarsal and the 5th tuberosity, and that's an AFO that we use to correct or prevent that ankle from rolling to the outside by that 3rd application force. Just about toes quickly. Because of the clawing toes, hammer toes, we get dorsal pressure and abrasion. So sometimes we use silicone sleeves just as a protective shock absorbing device. Footwear with uppers that have flexible, pliable and distal toe pain. We hammer toes. We also might use silicone devices that sit under the toes. I think this is the last one. So 1st and 5th metatarsal joint pain, so bunion deformities associated usually with hallux abductor valgus, hallux valgus. It's a pressure-related thing, so we want wide footwear with pliable uppers as well, sometimes incorporating shoe stretching, and if severe, this one's quite a severe gout-related condition, custom-made shoes. Thank you.
Thanks, Ben. Okay, Narelle, we'll go straight into you. Natalie, sorry.
Great. So thank you for joining me tonight, everyone. My name is Natalie, and I'm a podiatrist and a current PhD student investigating the effect of school shoes in adolescents with knee pain. So tonight my presentation will discuss when foot pain isn't plantar fasciitis or some alternative diagnoses. We'll start with a brief outline on what plantar heel pain is and the burden of it within clinical practice, patterns of plantar heel pain, and an update on current evidence within the space. Red flags not to be missed, just building on some of Mike's, and how these present within the clinical setting. And finally, what's within my podiatry toolkit to help managing plantar heel pain and help people return to being active once again. So plantar heel pain is a term that describes the presentation of pain or discomfort on the plantar surface of the foot. It is reported as being one of the most common musculoskeletal pathologies of the foot, treated by general and allied healthcare practitioners, and it is estimated to affect around 10 to 50% of people aged over 50 years of age, and results in reduced participation in physical activity, poorer mental health, and lower quality of life as reported by those who experience pain. Plantar heel pain encompasses an umbrella term that may describe pathology affecting tissue on the bottom of the foot. Most pain is generally localized to this medial or central aspect of the heel, and previously referred to as plantar fasciitis. The term was expanded as the anatomy of the plantar surface of the foot is so complex, therefore often other structures may be involved, with 4 layers of intrinsic muscles, many bones, joints and ligaments. The true diagnosis of the patient presenting with heel pain may include numerous structures, and so the etiology of heel pain can often be multifactorial and is often dependent on which of these anatomical structures are involved. Some studies suggest that its origin may be purely mechanical, resulting from a tractional or compression on the heel, while other tissues may become overloaded through systemic causes such as inflammatory arthropathies, type 2 diabetes. A recent meta-analysis investigated imaging findings in people with plantar heel pain found that they're most likely to demonstrate thickening of the plantar fascia, as well as changes in the fat pad and through the aponeurosis. And commonly on X-ray, a plantar calcaneal spur is noted. However, of interest, within studies comparing patients with heel pain to those without, 40% of those who don't experience heel pain also have the presence of a heel spur, suggesting that a heel spur may not be the sole origin or cause of pain in those presenting with heel pain. Proposed risk factors for the development of heel pain include intrinsic factors such as reduced ankle joint range of motion, a more pronated foot posture, increased body mass, as well as extrinsic factors such as footwear. Some of these risk factors have the capacity to alter and increase tractional strain on the plantar foot, which may contribute to increased pain through the heel. However, some literature rebukes this, suggesting that foot posture and ankle joint range of motion may not act as a risk factor to developing heel pain compared to those who don't develop pain. From a clinical standpoint, though, we know that restrictions in ankle joint range of motion, which are common, and reductions in foot strength are evident in more chronic cases of heel pain. And this may be due to changes in gait as well as a response to longer standing pain. However, addressing these restrictions may allow us to reduce tissue stress, which ultimately improves or reduces pain. And as a podiatrist, these risk factors and characteristics formulate the mainstay of my management plan, and treatment is often guided by addressing these or addressing some of these factors that may contribute to increased tissue stress. Using some of the flags. So with all of this in mind, in regard to generalized heel pain, so not the acute that may require a surgical referral, I'm just going to present a few tips for differentiating different types of heel pain by talking through a few red flags. So this is generally presented to us in the questioning phase of your consultation. As a podiatrist, I often gather most of my information from what my patient reports their symptoms as being, as opposed to just basing it solely on my objective assessment. So a number of the red flags I'm going to present are just some examples of foot pain which you can identify or separate with the patient's reporting of pain. So the first one is age. Plantar heel pain is common in children and adolescents, but it generally arises from a different source to adults. As you can see here on the X-ray and MRI on the screen, calcaneal apophysitis is highly prevalent in children and adolescents from ages 8 to 14, and it's a pathology that causes inflammation at the growth plate or the apophysis of the bone of the calc or the heel. And it often mirrors the presentation of heel pain in adults. But importantly, treatment of this does differ slightly to that of adults. So identifying that differential diagnosis early just allows the implementation of management sooner. That's more appropriate and allows children and adolescents to keep active. My second red flag is the pain pattern or the pattern of the pain. People with plantar heel pain that is often soft tissue in origin generally have pain with first step pain or after a period of activity. Of course, all cases are individual and may differ, but generally if a person is experiencing pain at night or when non-weight bearing, then the suspicion of bone stress or bone edema must be considered. And this again differentiates our management as we may look to offloading these patients in an offloading boot or a cam walker, as Ben spoke about, just to allow that inflammation to settle. Building on this again, my final pain pattern is pain that extends up the medial ankle from the heel. So pain that extends up the ankle is likely to involve structures external to the foot, such as the tibialis posterior tendon or the peroneus longus. If it's incorrectly diagnosed or management, consequences can include changes to foot posture, similar to what we can see here on the screen with the left foot. You can see that big medial deviation through her medial arch, medial ankle, a large amount of eversion through the rear foot. And this patient experienced a lot of an increase in medial knee joint loading, lower back pain, posterior hip. So if incorrectly managed, sometimes consequences can include these kind of longer term changes. So as a podiatrist, my goal is to manage causative factors that might be contributing to or increasing symptoms of plantar heel pain in both chronic and acute conditions. Diagnosis is often paramount and essential to the implementation, and we generally focus on managing symptoms and addressing the causative factors that are contributing to their presentation. As part of symptom management, we may use taping techniques, often in the initial visit, as well as advice on ice, heat therapy, and general anti-inflammatory suggestions. Shockwave therapy may be used to increase healing factors, dry needling, soft tissue treatment, mobilization or manipulation, just to get things moving if it's been a more chronic case. In cases of bone stress, offloading devices similar to what Ben spoke about, as well as load management advice and anywhere that we can monitor this to just reduce the load in the short term. Within an initial assessment, we will assess someone's gait and complete a plantar pressure analysis just to identify any asymmetries or peak loading points that may be contributing to the onset of their injury. And a footwear assessment is generally pretty paramount, and it's something that I feel contributes hugely. The majority of our society has been in shoes since we were very, very young. So our footwear contributes massively to the presentation of pain. So for people with heel pain, making sure that they're in a shoe that has adequate cushioning, isn't too flexible through the midsole of the shoe, and has adequate fixation, just so that a number of those intrinsic foot structures don't have to work harder than they need to. Mobility exercises are also really important, as well as strengthening and stretching prescription for the intrinsic muscles. There's a big amount of research being investigated into the role of intrinsic foot muscle strength and the risk of plantar foot pain or heel pain. And so making sure that we're targeting these muscles, which often don't work very hard when we're in footwear or orthotic devices for a long period of time. So making sure that we're targeting this or spending a little bit of time barefoot and strengthening those tissues should help with long-term management. So that concludes my presentation. The foot is really complex, and as we've seen from some of the earlier presentations from Mike and Ben, presentations of foot pain can really reflect this, and it can differ between people as well as between the left and right foot in some people. My main focus is just to focus on subjective assessments, and I hope that some of the points that we've presented tonight can help you in managing some of the next difficult cases of foot pain that you come across. Thanks for your time, and I'm happy to answer any questions.
Thank you, everyone, and thank you to the three speakers. I do have a number of questions. We may go over a little bit by 8 o'clock, but I think that's probably okay. Michael, cause of a tibialis anterior rupture injury, ? Inversion ?
No, so the most common, there are two groups of patients who present with the tibialis anterior rupture. There's the most common presentation by a long way, which is patients who have a degree of degeneration at the insertion of the tibialis anterior, and they have an attritional injury. It's often associated with osteoarthritis of the first tarsometatarsal joint and osteophytes. And usually what happens is they have a forced plantar flexion, so the opposite of what happens with an Achilles, and it ruptures. The second group, which is very rare, I only see one or two a year, is when it's in the younger patients and someone usually drops something on the front of their ankle, and there's a force applied to tibant. To give you an idea, the last guy I saw who had that had a steel girder dropped on the front of his ankle, so he had a soft tissue injury and an associated tibant rupture.
Thank you. Next question for you, Michael. Please ask Michael re Lisfranc whether CT is better than WB X-ray to look for diastasis. Thanks.
Diastasis. So first and foremost, so all patients who you think have got a fracture in their foot should start with a plain X-ray. The CT scan is your second line, and you will often get the diagnosis based on the CT scan. A diastasis is best, so if it's an obvious displacement, you'll see that on the CT scan, and the majority of Lisfranc injuries are diagnosed and the investigations really stop at that point. There's a group of patients who have more subtle ligamentous Lisfranc injuries who have a normal X-ray and a normal CT scan. And then the two investigations that you have following that are a weight-bearing X-ray, which is limited. When you're getting a weight-bearing X-ray, it's very important that you get them to X-ray the patient's other foot to make sure that you've got something to compare it with. And you also need to make sure that the way that the X-ray is taken really gives you a good shot down the midfoot, and that's not always done. If you're suspicious that there's a diastasis, then the gold standard for doing that is really a thing called a weight-bearing CT scan. We don't have access to that in Geelong, but there is one, there's a couple of them in Melbourne. And what they do is they basically scan the patient's foot in a non-loaded fashion, map the surface area within the Lisfranc joint, then get them to stand within the CT scan. It's mounted on horizontally on the ground, so they stand in it, and then they look at the change in the surface area within that, the diastasis. That you can also use that for suspected syndesmotic injury. But if you're getting to that level, most of the time the diagnosis is really made off the CT scan alone.
Thanks, Mike. I do have a couple more questions. There's one for Natalie and there's one for Ben. We'll start with Natalie. Natalie, as pictured, do you use calf raises to strengthen calf in patient with plantar fasciitis as well as foot intrinsic strengthening?
Yeah, so generally we'll do a combination of strengthening to address extrinsic tissues to the foot as well as intrinsic. So generally we'll incorporate calf raises, sometimes seated calf raises to target more soleus, and a lot of intrinsic muscle strengthening to address like abductor hallucis weakness or any increased load through the flexor tendons. So generally not just focusing on one muscle, but focusing on a few that will affect foot posture.
Okay, thank you. Ben, you mentioned shear force reduction. What materials on an orthotic do you use to reduce those forces, particularly for healed DFU? You're on mute.
There you go. Yeah, so for your high-risk foot, your neuropathic foot with DFU, a lot of it's about pressure distribution and mapping the right, taking away pressure and adding pressure in all the right spots. But there are shear materials you can simply use. Silicone inserts you can buy from pharmacies can help sometimes. They reduce, I guess, the shears taken by the silicone rather than the underlying skin. There are materials we use them. They're called Poron. They used to be called PPT. Different materials that are like a viscoelastic. I'm not sure, like an EVA, I think, like a blow-on rubber. But we just place those materials in the spots where it's needed. You can also get linings that are just like a 3 millimeter lining of that same material. It's just more cushioning. The silicone's probably better for shear forces.
Okay, I don't have any other questions at this stage, so I will finish the presentation this evening and thank all the speakers for their presentations, and yeah, fantastic talks by everyone. So thank you for taking the time to speak to our members, and if you do have a think or got some other further questions for our presenters, just type them in your questionnaire in your comments section, and I'm sure I can pass them on to the presenters for you. So thank you again, and please don't forget to fill out your evaluation and any other topics for our session 2 of our orthopaedic series. Pop them in there because I haven't organised another topic yet, so please do that. So thanks everyone for attending. Have a good night.
Thank you.
Thank you.